Today he's going to talk about how faith informs a response to science and uncertainty, and how love shapes our collective life in the midst of disruption and fear. So with that, we're going to have questions afterwards. So if you have questions, be prepared. And I'm going to hand it over to Mark.
Thank you, Murray, and thank you for being here. There we go. So I want to talk about Anabaptist faith in the time of COVID-19, and I'm really glad to have the chance to give this talk. It's routine in formal presentations in science to have a disclaimer slide. My employer has not had the chance to say that they disagree or agree with what I have to say, so I'm not speaking on behalf of my employer. In addition to that, the statement is usually said, so no one's paying me to say these things, so that's not my motivation. My motivations are significantly different. I've been a practicing physician now for over 25 years as an infectious disease physician, and I come from a family of physicians. But even for longer than that, I've been an Anabaptist Christian. And I believe that my faith in Jesus informs my living. And I've had to give a number of talks on COVID-19, but I haven't been able to walk onto those areas. And I'm really glad to have the chance to do a talk where that's okay. So here's where we're currently at, a significant pandemic a year later. The novel coronavirus, it's getting kind of old, I think, but we have to deal with where we are at the current time. And I want to sort of acknowledge the fact that, you know, the Johns Hopkins ticker, or the WHO ticker, says we're up to about 126 million confirmed cases. That's about 2% of the world population. And we know that it's more than that because we haven't been able to even keep track of how many people are involved. There have been 2.7 million deaths attributed to the coronavirus. And I want to just really recognize that that is a significant weight that many have. The loss of a loved one, the loss of an occupation or employment, the significant amount of disruption that this has caused to all of us, really. What I've realized is that a significant portion of being an epidemiologist at a time like this is to deal with the fact that there's fear. Now, fear serves some good purposes and keeps us from getting into trouble sometimes, but it also tends to degrade our behavior. And we do things out of fear that may be self-protection or maybe self-attention, and are not always the wisest thing that we can say that we've done. In addition to that, one of the difficulties here is uncertainty. There's so much information. And there's so much that's unknown even after getting all this information that has been difficult. Some people have said, I could take just about anything if you would just tell me when this is going to be over and perhaps what over looks like. So what I want to try to do in all of this is give some sense as to what it is that we know, not what, can't tell you what we don't know, and how we should take it from there. We know that in a time like this, you know, what would Jesus say? And it's actually interesting that it's coming now, you know, coming up onto Easter. Jesus said to the women at the tomb, do not be afraid. Jesus said, taught his disciples, do not be afraid. In fact, in Revelation, the Lord said to John, do not be afraid. And I think there is something that we need to have as Christians in this regard. As someone who's trying to read the articles, it's kind of difficult. In the scientific literature, there's 113,000 papers. Oops. That does not include all of these other things that we've been seeing. There's all the stuff that's out on the web, the gray literature. There's the government websites and other websites. There's news media, there's social media. How can you ever keep up? And this is how I think all of us feel, drinking from the water hose, feeling deluged with all of the different sources of information. What possibly could there be in here to know, and how many things we don't know? And I think really what I want to take is a couple of lessons about what we do know and see how they all relate to this. In essence, part of what I want to do is sift through all of this and see what matches truth so that we can hold on to that. First, some of the bad news. We know from this disease, and very consistently, this is from the CDC's website, but very consistently, this is a severe disease with a high mortality in those who are older. If you compare to a young adult, someone who's 85 plus has 500 times the risk of death. And unlike this curve, which usually has a really high spike in the early years, that's not what we observe here. So this is some of the difficult news about this virus. A significant mortality that is much, much greater in those of older age. The good news, perhaps, is that the case fatality ratio, the number of deaths divided by the number of cases, has been going down quite nicely since the early months of illness. I'm not sure exactly why that is. It isn't just because it's younger folk. It isn't just because we're taking better care of them, although there may be elements of that. But for whatever reason, this has been and is fairly consistent. Right now, the average worldwide is about a 2.1% mortality. But if you take the countries and look at the median, it's 1.7, and I'm sorry, that's the interquartile range, not just the full range. But think of it as the mortality worldwide is somewhere around 1.7%. And it's getting a little bit better. One of the difficulties with this virus is that I think it is tuned to mess with our minds. Nowadays, with the very short news cycles and the information passing around so quickly, it is difficult to deal with a pathogen that has this time course. From the time of exposure shown here in a red circle, it's usually 5 to 7 days, but anywhere from 2 to 14 days that somebody will start their illness. They may or may not have a symptom onset. The infectious period starts for about 2 days before and actually extends to 5 days after, although there may be some people who could transmit out to 10 days or maybe even 20. Deaths or severe respiratory decline, which usually is what prompts going to the hospital, may not happen until 7 to 10 days after the symptom onset, and actually fairly rarely happen at the time of symptom onset. This is something that gets worse over the course of a week to 10 days, and that affects how we pay attention. And then for keeping track of things in a community, you'll read in the paper the cases are going up, and then you'll read in the paper that the deaths are going up, and then you'll read that the cases are going down, and then only weeks later will you find out that the deaths are going down. So it ends up being confusing, particularly in this time of short attention spans.
Mark, our interpreters are asking that you slow down a little bit.
I was, there must be a connection here, because I was just thinking, Mark, you're going too fast. My apologies. Je m'excuse. Okay, so what do we know? Well, when we first found out that this was a coronavirus, we knew that the other coronaviruses are spread by respiratory droplets. Usually we think of that in terms of 1 meter. When SARS-1 came around, we kind of extended that to 2 meters out. Some activities seem to produce smaller droplets and are a problem in that regard. So we have to be careful about certain aerosol generating procedures such as intubation. And that there's always been the theoretical idea that you could bring contaminated hands or contaminated objects to touch your nose or your mouth or your eyes. There are other routes that are possible, such as stool, but those are much harder to prove. We also know that with SARS-1 and the MERS-CoV, symptoms onset tended to happen right about the time of viral shedding. We don't have that luxury here. And those two illnesses had a higher mortality rate, 10% and 30%. So we know a few things from contact tracing. Almost all of the cases of transmission happen after contact with somebody within 10 days or within 5 days of their illness onset. Incubation is 2 to 14 days, and that most of the transmission happens by extended periods of time around somebody within 6 feet of an infectious person. Transmission can occur even before or in the absence of symptoms, and that was one of the early confusing aspects. When we could not test as much and did not know as much as we do now, we didn't know that efficient transmission can happen even before you feel ill. The studies have shown that there are about 2 to 3 people infected for every case that occurs, although this number may be highly variable depending on the environment. Those interesting exceptions have often happened in settings of congregate living, in nursing homes or in homeless shelters or in prisons and elsewhere. There's been seemingly a different amount of transmission. So how is this transmitted? Well, when an infectious person is coughing or sneezing or even breathing, they produce a number of droplets. And there are droplets that vary in size from pretty large, basically the largest ones there would be visible, to very small, the smallest ones being about the size of a naked virus. And so there's been a debate as to whether this is droplets or aerosols. Doesn't change the fact that the aerosols are most concentrated close to where the aerosols are produced, but it still has resulted in a debate between aerosol scientists and infectious disease folk. When we think about droplets, we think of other respiratory viruses like influenza, rhinovirus, or adenovirus. When we think about aerosols, we're more concerned with tuberculosis or varicella or measles and patterns that are involved there. I think since this is an Anabaptist group, I'll tell a story that relates to a gathering around the table. Family A was celebrating Chinese New Year in an area of China that did not have illness broadly. And that number of people who were at the table with the yellow infected person became infected. But some of the people who were within the air conditioning circulation at tables B and C for about 45 minutes to an hour also became infected. And those distances were greater than 2 meters. So because of this, people said, you know, we should be treating this more seriously than a simple droplet transmission. However, you can see here that that room was larger than you see here. And there were tables E, F, G, and a number of other tables. And nobody at those other tables or the servers who did come and take the order and bring the food became infected. So from that standpoint, it's really acting like influenza and other respiratory viruses, although we now have a significantly greater respect for the tiny droplets, the ones that are smaller than 5 microns. We produce droplets when we breathe, when we talk, when we sneeze. So we're producing them all the time. The aerosols are being produced continuously, and for those of us who are talking loudly, more aerosols are produced. So there are a number of different factors which increase the number or size or volume of particles that are produced. As you can see here, some congregations have used it as very encouraging that loud singing behind a face mask produces not that much more than simply breathing without a mask. So do face masks work? Well, before COVID-19, there was actually very little evidence. I couldn't find any articles that talked about it, and we had a couple of abstracts. They said that if you're trying to wear a mask in order for you not to become infected, when everybody else isn't wearing a mask, they don't work very well. And so when masks were in extremely short supply, there was initially some statement of, don't take a mask away from somebody who is going to take care of somebody who's infectious. What we know now is there's a very important role that my mask plays in protecting others. My mask is most effective in protecting you if I am infectious. And for that purpose, if we all wear masks, we are showing our care for those around us in case we don't know we are infectious. We also know that there is some added benefit for the person who's wearing the masks in an environment where the virus is being spread. Universal masking has been now tested and shown over and over again that when there are country mandates to do so, the rates of transmission fall predictably. That's also true in communities and counties over and over again. One county does it, one county doesn't, and there is more illness in the county that did not have universal masking. This goes down to the level of measuring how often you wear a mask when you are at home with an infected individual, or as an individual when you are out in the community. So the value of face masks in this situation has to be put into the pretty impressive. There's no pill that does this well, does it this well. Masks come in a variety of fit and filtration. You have the cloth face coverings, which do catch what you spit pretty well. They are not consistently reliable at blocking what you bring in, but they are suitable in most cases to use across the board. Medical masks have to pass filtration limits, so they filter out 98% of bacteria-sized particles and 80 to 95% of virus-sized particles. They've been used to catch a surgeon's oral output, but they're generally loose-fitting, and so small particles could get around the mask and be breathed in. So there are specialized fitted masks. In the US, they're N95s. In China, they're KN95s. And I don't know, there are several other ways that they're labeled, but they filter out significantly more than 95% of those virus-sized particles. They, in general, have to be fit to your face. Not everyone's face is the same. And for that reason, there should be a program that figures out whether or not these are fitting well enough around the face. And these are what we use when we're taking care of known infectious patients in my hospital. There are other ways to prevent the spread if we maintain that physical distance. If we keep exposures short exposures, passing in the hall, even talking briefly, have a very low likelihood of transmitting. And so in general, we have used this 15-minute cutoff. It, of course, is an approximation. There are some times when you've been at some distance for much longer than 15 minutes and there's been no transmission. But there have also been some cases, particularly when people have been doing intubation and have to get very close to someone, where even a shorter exposure may be a risk. Washing hands is important. It's hard as an infectious disease doctor not to put that in any and all recommendations, but it's particularly important if you have touched a contaminated fluid and then you're going to touch your nose, eyes, or mouth. Open and well-ventilated spaces have a much lower level of transmission, and they are encouraged. What we know is, and this is just one example of many counties that I did earlier, that I looked at earlier out of public data, but you can see how that spike went up quickly. My grandchildren are in that county and I was nervous. They put in place mitigation measures like the ones we've described. And this is the good news. We do have ways that can, on a community level, reduce the level of transmission. Mitigation works. there is a variety of levels of protection. We know that wearing a mask is important. I actually put above that the idea that if you are sick, you should not work. If you have I should say, if you have a infectious disease or think that you have an infectious disease, you should keep yourself apart from others. That's isolation. And that is key to reducing the spread. Quarantine, which involves public health, is the idea that you've been exposed. So you've been informed that you have been exposed to somebody who was infectious during their infectious period and should prevent that. I think that we are going to be much more reluctant to work when we have this new cough or this new fever or this new illness and take it to those around us now that we have experienced this pandemic. Wearing a mask, as mentioned before, the size of gathering matters because it increases the chance that one person in that gathering would be infected. So in addition to these various methods of prevention, there is a new approach, a new tool that has come up, and I would not have been able to predict that we would have been able to successfully have one vaccine for emergency use, but the current status is that there are over 100 in clinical trials in some way, and there are 9 that are at least in emergency use in various places. Whenever the number of vaccines gets that large, I think it's important, or it's easiest for me to think of them in bunches. You have the messenger RNA viruses of vaccines, which code they give your cells the code to produce the spike protein. They are out there and in use, and this is a brand new platform. We haven't successfully done this before. They work. The catch is messenger RNA is very fragile. Put into the body, it's gone in minutes to maybe hours. And for that reason, even in storage, it has to be kept frozen, and that's very difficult from a cold chain standpoint. The viral vector vaccines, they happen to all be using an adenovirus strain, are many. They include the AstraZeneca and the Johnson & Johnson, as well as the Sputnik and a China version. They require less stringent storage. Think the cold chain required for a yellow fever vaccine. Certainly doable in basically all health systems that are doing vaccine that way. I'll jump to the bottom. Inactivated vaccine virus is the easiest way, or the most simplest technology. You basically grow up the virus and then you inactivate it. And there are a number of vaccines in that category that are out there, although they have received significantly less press. Similar to inactivated vaccines are protein vaccines, where you take just a subset of the virus. In this case, Novavax is the closest to being out there and approved. They're usually given with another chemical which causes more of a reaction around that protein. So we have these many different tools coming to us from very many different directions. So why is it that there's such a controversy around this and so much detractors? I wanted to address directly some of the myths that have been around this. None of these vaccines get into the human nucleus and alter the human DNA. So there's no aspect here that they are changing your fertility or giving you cancer or anything like that. And in fact, when pregnant women were part of the trials, they have done well from that standpoint. The vaccines can't give you COVID-19 because they are just one simple part of it. They are not the entire vaccine, and they are inactivated if they are an inactivated vaccine. The other piece is that these vaccines are being made by China, Russia, the US, the UK, in Europe, but in India. I can't imagine a global conspiracy that would get all those governments to cooperate. So why do all these myths happen? And I think that there is something about fear that's contagious. It's sometimes entertaining. It certainly brings about personal attention. And I think we as Christians should be testing the spirit of what people are saying. Does this make sense? Does this sound true? Does this sound plausible? Jesus aligned with truth rather than making up stories to sow fear, even though he knew many things were to be feared. I think some have experienced personal gain for distorting the truth. I think others have used these false narratives to specifically target the other political party, the other people, and to take our attention away from the fact that this is really a battle of us against the virus, not us against other people who are doing this to us. There are a number of different passages that come to mind when I think about the fear that people have been living on. And this 1 John passage, God is love. Whoever lives in love lives in God and God in them. This is how love is made complete among us, so that we will have confidence on the day of judgment or other days of trouble. In this world, we are like Jesus. There is no fear in love, but perfect love drives out fear, because fear has to do with punishment. The one who fears is not made perfect in love. I think the shortest statement about what is Anabaptist faith that keeps sticking with me is that, and I can't remember where I heard it, Jesus meant what he said, and he was talking to us. Jesus aligned himself with truth and has given us the instructions that we should love our neighbor. We should, as a faith community, be bathed in that concern for the other over concern for self. I believe that wearing a mask and attending to the public health measures helps show love for our neighbors and is completely consistent with that. The vaccination is a welcome tool, and I thank God that we have these tools to fight this virus. The crisis has brought on many false tales, I would say false prophets, who sow confusion and abandon the truth. I hope we're known as the people who always love, keep the faith. So we have some time for questions. And my apologies for talking so fast.
Perhaps there are things also that you may want to clear up in your mind. Some, if it was too fast, go ahead and ask a question on clarification. And
Gracias, Mark, Shelly, por lo que nos has compartido. Bastante interesante. Definitivamente un desafío que yo veo a la comunidad anabaptista es justamente cumplir ciertas regulaciones estatales. Ya desde que el punto de vista de fe siempre se ha creído una separación intrínseca entre el Estado y la Iglesia. Y algo que comúnmente he vivido en estas comunidades de fe, que ha sido una lucha constante en este año de la pandemia, es hacerle la conciencia a las personas desde un punto científico por qué es importante, por ejemplo, la distancia física y el uso. Bueno. Y el mayor desafío en las comunidades, ¿sí?
Yeah, I think that is a...
Okay. ¿Puedo continuar?
Okay. I think that gets to a significant issue with, so who do we listen to, and how do we deal with this? I have struggled quite a bit with how our churches will get together once we, have a lower rate of transmission in our communities, how we can do that, and how do we maintain some element of connection. I do like the term physical distancing rather than social distancing, although I use the more common term. I've written more letters and talked to more people on the phone or over Zoom than I did before. But I hear you, brother. One of the things that I miss most of all is singing.
We have another question here from Canada. A lot of the public health measures have resulted in apparent elimination of the flu and cough and cold season, but COVID still spreads. Can you explain this?
I think that the incidence in the population is one of the key issues. And so the presence in the population, the numbers that people give, are often in terms of 1 in 1,000 people in your county will have it in the next week. If that's the rate, it's there and it's ready to spread. Whereas if influenza is around and it's at a much lower rate, it doesn't spread around. The other thing is that even our background immunity to something like influenza is significantly greater. So those of us who have been immunized against flu, et cetera, make it harder for it to spread around, whereas the susceptibility to SARS-CoV-2 is significantly higher. So I think those are two things that go together. I do think that there's a lot to be learned from the fact that, wait a minute, there are tens, hundreds of thousands of deaths from influenza every year. And we've sort of said, it's just gotta be. And maybe it doesn't.
Mark, it's Don Dirksen from Winnipeg. Thanks for a great talk. A question regarding two things. Number one, what do you think about the variants and their threat? And number two, if you were to speculate, let's say 6 months from now, where do you think we'll be with respect to this virus?
Well, I think RNA viruses don't copy themselves very well. They make mistakes, and so we will get variants because RNA viruses do that. We were initially hopeful that the repair mechanism that this virus has in it would reduce the amount of variants. But it is clear that with so many people infected, and we think of this as each infected person having trillions of virus, there's lots of opportunity for mutation to happen, and mutations which give an advantage to the virus begin to show up. So I think exactly what's going to happen related to the mutations is unknown, and I don't think the total number of mutations is finished yet. But if we reduce society's transmission, that will help us to reduce the opportunity that the virus has to mutate. And in addition to that, it will give a better chance for some background immunity. It also brings up the issue with vaccinations. Will the vaccinations work against the mutants? And actually, they have done, I would say, better than I would have expected. Every year, we have to keep tweaking the influenza virus. And given the total number of disease cases, I think that it has done, they have done reasonably well when looked at side by side. But those are some of the things that are yet unknown and are still out there as far as how that would go. The other part is the question of where will things be in 6 months? I have been cautiously optimistic about the decline from what, at least in the US, was a significant and welcome decline that happened in January to February. Unfortunately, I think as long as we have as much background transmission, we are at risk for things blowing up again. And what I've noticed, and I think it has to do with this, how much attention span do we have? I'm still thinking of people basically throwing up their hands and saying, I'm so done with this. I got my vaccine, I'm done with this. And they want to return to exactly where it was before. So I see all sorts of variations in that path for the future as far as that goes. However, I'm hopeful that with more people vaccinated, I can at least start considering some socially distanced vacations outside of central Pennsylvania.
I think it's interesting that when it comes to pandemic, really the key prevention piece is thinking about the other. So it's just really interesting. When you think about yourself, it actually doesn't work very well. But when you think about the other, that seems to be the treatment for a pandemic. If everyone thought of the other, we wouldn't have a problem, perhaps. Well, we'd have a problem, but it would be a good prevention measure. Just wondering then, a lot of people in the Anabaptist community like to get together and for Sunday morning services or whatever it is. There have been churches that have, of course, fought this sort of rule against getting together. Yet, in our area here, gyms are open, other non-essential services are open, but churches aren't. So it's do you have any response to sort of the varied approach to what's open and what can happen, what can't happen in terms of gatherings?
Yeah, I think what you end up finding is that there's a very significant difference between one person's fear of the disease and another person's fear of disease, and so you get a lot of variation even within that. And then you'll have, one church is very active and another church, shut down, and you're never sure when they're going to open their doors again. So I think this is a very difficult issue. It's one that I don't think we have the answers to yet. I'm personally looking for, so if ventilation is important, how do I measure that ventilation to know I've arrived there? The other piece that I know in regards to this is that many times the science is taken by those who are trying to figure out what to do. And so they may be influenced by their own life and their own efforts of what to do. And I think that some of the decisions about saying this can't be open, this can be, are different. I think for churches, when you are getting back together again, while we're still in this time, I think masks will be a part of that story for, well, at least the next 6 months.
I think we have a hand up.
Dodanim.
That's you.
Sí, sí, gracias. Sí, no logré completar mi pregunta. Uno de los desafíos que yo me he encontrado más comúnmente en las comunidades de fe anabaptista aquí en Guatemala es que hablan de que por fe no se van a infectar del virus. Entonces, ha sido un desafío constante tratar de implementar protocolos para el regreso seguro a los cultos o servicios normales, porque mucha gente pone su fe a prueba, ¿verdad? Y es algo un poquito más complejo de hablar porque tal vez para nosotros que somos profesionales de la salud, entendemos el concepto de distancia social, entendemos el concepto del uso de mascarilla, entendemos el concepto de higiene de manos, uso de alcohol, que son cuestiones básicas para la prevención de muchas enfermedades virales y bacterianas como la tuberculosis, ¿verdad? Nosotros en Guatemala también estamos atravesando una pandemia de tuberculosis espantosa que ha sido bien difícil de controlar por el tema de la resistencia a los antibióticos. Pero como red global, yo me preguntaba qué más podemos hacer para hacer conciencia a nuestras comunidades de fe de que la fe, pues sí, es importante, pero también somos creacionistas un poco ahí, creemos en la ciencia y cómo la ciencia nos ayuda. Por ejemplo, hoy por hoy, por ejemplo, en Guatemala no sabemos cuánta gente de las comunidades anabaptistas se ha enfermado de COVID y cuántos han muerto por COVID. Porque nos enteramos a un familiar, porque el otro tema difícil aquí es que se ha estigmatizado a las personas que se han contagiado por COVID. Eh, eh,
Hermano,
Ujú.
podemos pedirle a Karen que interprete. Su pregunta es muy importante y queremos darle la oportunidad a Mark que responda.
Bueno, sí, yo estaba esperando que Karen me dijera para traducir, por eso me callé un poquito.
Okay.
My bad English language. Um, for Guatemala, it has been really difficult to manage of the COVID-19 pandemic. We don't have data, precisely data for how many people have been infected or our Mennonite community. It's can be more difficulties to making them understand why so use all the measure to prevent the contagious of this virus. The use of masks, the wash of the hands, and the distance socially for our cultures have been real difficult because our culture is like we give the hand, we give kisses, and it has been really difficult to abandon this practice. Ah, ya tradujo la hermana, ok, gracias. Entonces continúo en español. Entonces, yo diría que para la red, cómo enfrentamos juntos en ayudar a nuestras comunidades a entender que por un lado está el componente de fe y por un lado también está el componente físico para implementar el contagio. Se han hecho muchos esfuerzos porque la pandemia no solo ha desnudado los problemas de nuestro sistema de salud, sino que ha desnudado la pobreza extrema. Y según los indicadores económicos, estamos esperando un golpe económico aún más fuerte para nuestras comunidades, que ya por la situación económica en la que viven nuestros pueblos, por la situación de corrupción, ya sufren, ¿verdad? Entonces es difícil implementar cuando la gente ni siquiera tiene agua potable, ¿verdad? Entonces, eh, ¿qué podemos, así como Max Shelly, que estuvo 9 años en el Congo, qué podemos nosotros hacer? Cuestiones básicas con pocos recursos, sin datos para trabajar, hacer la conciencia suficiente en nuestras comunidades de fe para trabajar y cómo nuestra red puede ayudar a mejorar el intercambio de información y que ésta pueda llegar efectivamente a las comunidades de fe, porque miren, a los médicos no nos están escuchando a los que son pastores, ¿verdad? Y muchos...
We're going to have to cut this really short now. Do you have just one question we can ask Mark, perhaps?
Gracias.
Do we have Karen, can you come up with maybe one question that we can get to Mark on that?
Bonjour Mary. Allô?
Yeah, the one about, you know, why won't God protect me from all illness uh, and all sorrow is a difficult question, which really deserves the pastors and all of our wrestling. But it is clearly observed that churches who decide to meet and uh, greet as openly as they can have suffered many and high degrees of transmission. So that's what we have observed. It is not, I believe, their lack of faith that has resulted in that. Now, one of the things that I see as really good news in what we've understood about mitigation is that we have many tools that are inexpensive. God has given us the air around us, and we can get together in areas that are open, less crowded. We can open the door, open the window to experience the presence that we need. One of the other things that I think is important is to recognize the size of your contact circle. So whereas we might like the idea of getting in a stadium with 100,000 people, that isn't the way that we should be doing things when there's a pandemic. We should decide, these are the families, the small group that I would get together with, and I will do this. And I will do those things which are simple and available to me. And I'm glad it isn't a pill that you have to take to prevent this. I'm glad that these simple things available to all of us can be helpful.
There's two other interesting questions I want to get to yet. One is there any specific medical treatment for COVID-19 presently?
The way I look at it is this: I think that there are various treatments that have done good for some people, and I do believe that we're finding that. One of the things in the deluge of information that's out there is I want to avoid trying to fit all of those possible treatments into a short presentation. So I think that that's an area. I tried to give information that I view as very unlikely to change with new information coming in. I believe that our understandings of treatments will change. I know that patients who are admitted to the hospital, patients who are elderly who get disease are often treated with antibody or serum treatments early on in illness. I know that we use the antivirals sometimes. We certainly use steroids when people are put on the ventilator or when they have severe disease and are hospitalized. But beyond that, I think that essentially what's called for is good supportive care, that many who get this disease will have the need for oxygen, and that respiratory failure will be the key aspect. And so we need to do the best possible support that we can. The other thing is reducing transmission results in less overwhelming our health systems. And that in March and April, what happened in New York City, or what in January of last year, what happened in Wuhan, was essentially a total overwhelming of the healthcare system with some of that high incidence of death. So I think that doing the things in prevention and caring for our neighbors and keeping this transmission low will in the end result in a net benefit to our health systems and less serious outcomes and death.
Okay, another question here. What do you say to those who say the universal restrictions that we've talked about here are overblown? There's some argument, I guess, that for the younger people in good health, it's not deadly and can just be treated like the common flu.
Well, that's very interesting, and in many places they're in a university town, and that's what universities were saying. Why are we so nervous? They're the people rarely get ill. It turns out that some of the university students were very severely ill. But what you notice in those communities is somewhere around 3 or 4 weeks later, you start to see the rise in cases in the elderly. And the point is that we do not live in a society which segregates us all by the year of our birth, thankfully, because we all want to see the grandkids and enjoy that. So I think that there's a responsibility across the board, and we certainly know that the virus can be amplified. The number of people who are infected will increase in those situations. I'm glad that they didn't have the high mortality, but I am fully aware of the fact that that comes at a societal cost, and I would like us all to bear together the costs of preventing the virus. As to exactly how much prevention is necessary, I think we will eventually look back and say, that was the most important thing we did, that was the least important thing we did. But I hope that these basic measures, if we embrace them, will be key to keeping us on track.
Okay, are there any other questions or comments on this?
Hello, Mary. Hello.
Hello.
Oui, j'ai une préoccupation pour Shelly actuellement avec le vaccin AstraZeneca. On a parlé de complications thromboemboliques des patients qui ont été vaccinés. Et déjà, dans plusieurs pays, ont eu à suspendre l'administration de ce vaccin. Et surtout chez nous, en Afrique, il y a eu très peu de... Sinon, en fait, l'Afrique a été relativement moins touchée par cette pandémie et beaucoup de personnes ne croyaient pas. Et puis avec...
la population est en train de négliger les mesures barrières. La question que je voulais poser, comment on peut briser les barrières dans ces milieux où
ces explications de
la population est trop jeune,
ils sont de plus en plus sceptiques pour le vaccin. Aujourd'hui, c'est sûr que des cas de décès qu'on a connus n'ont pas été réels à ce vaccin. Et donc, c'est sûr qu'il y a aussi d'autres complications qui peuvent arriver après.
I think that what happened with AstraZeneca's vaccine and the brief concern of an increase in clotting was actually a good example of people being very...
Tu m'as suivi, Shelly?
Yes, Delphin, we've got, he heard you and he is answering the question.
So what was happening there was a good example of people trying to make sure that there was no new evidence of a very rare side effect. The final answer to that is that they looked at it and said, there really doesn't seem to be any higher rate of those clotting events than there would be in the general population. But when you're talking about extremely rare events, this is difficult to balance as a whole. The countries that stopped using AstraZeneca have, for the most part, resumed using it after that analysis of the information. But the fact that people were willing to look closely for new signal of possible harm is a good example of a working system that is trying to make sure that we aren't causing more harm than good. At this point, I see no reason to take any one of these vaccines as a higher side effect vaccine than another.
Are there any other questions?
Murray, there was the question about inconsistencies in some countries when perhaps sports teams of 20 or so youth are allowed, but then youth groups in churches are told that they should be much smaller, 5 or 10. How do we, the question is for Mark, how do we deal with inconsistent messaging?
I think some of those decisions are made by people with different levels of interest, and rather than trying to think about what the whole answer is. And part of it has to do with who you want to see. I know that in our local area, it's the football team, and the school football teams want to still be able to play, and they'll put pressure on, whereas some of the churches have been more reluctant because they have older congregants. So a lot of that tension. And I think the answer is, this is messy, and we come up with inconsistent answers and wish that we could be at the table and make truly balanced answers. I don't think that we are. I think that many decisions are made short of having all of the evidence. But right now, I want communities to know, and I'm back to the sort of the Guatemala situation, we have to know what the level of transmission is in our areas. So right now, most effective areas are testing 1% to 2% of their population every week. From that standpoint, I think that testing is important, but it's also important for people to know that while there is so much transmission around, you will often transmit 2 days before you realize that you are very sick and wouldn't want to give this to anybody.
We have time for one more question. Okay, with that, I think I'm going to hand it over to Rolando. Oh, sorry. Looks like there
Oui,
is someone.
j'avais une question.
Go ahead.
J'avais une question.
Go
J'avais une
ahead.
question.
Yes, go ahead.
C'est par rapport à ce que nous sommes en train de constater dans la ville de Bukavu. Et le coronavirus circule à petit bruit dans la population parce qu'au moins chaque semaine, on enregistre quelques cas à l'hôpital de Panzi où je travaille. Maintenant, nous voyons que dans les lieux publics, beaucoup de gens ne portent pas de cache-nez et certaines personnes aussi ne respectent pas les mesures barrières. J'étais en train de poser une question par rapport aux stratégies pour briser les barrières des changements dans la communauté, surtout de Bukavu, qui jusque-là continuent à vivre. Effectivement, ils ont peur de la maladie, mais ils ne respectent pas les mesures barrières. C'était ça ma question.
I think that it's difficult in a situation like that because it's hard to know exactly how much disease is around. Perhaps the idea of getting rid of any idea that this is a minor problem that can be easily brushed under the rug is important. But exactly how to convince people of an enemy they cannot see, and that requires us to cooperate in order to reduce the harm, that's a difficult situation. I don't know the easy answer other than to say this harm is there, and it has become overwhelming in many situations. Maybe it will, maybe it won't in your community in Bukavu, but it's hard to know. The other thing is that it is difficult to fully recognize that in some areas the rate is 5 per 100,000 per week, and in another area the rate is 500 or 1,000 per 100,000 per week. The advice that I would give as a public health person would be very different in those two environments. And it's unfortunate that we have tried to make one message fits everywhere. However, I would suspect that one of the difficult things is to be able to identify exactly where you are on that very broad spectrum of experience of this pandemic.
It's a particular challenge when answers are not black and white. Answers are gray, and we have to sort of sort our way through that. And particularly in Bukavu, where I'm sure people have difficulty social distancing and other things, it's problematic. So at any rate, I'm going to, with that, I'm going to hand it over to Rolando then.
Okay. Thank you very much, Dr. Shelly, Mark, for this very informative and stimulating discussion. And I'm sure that I'm hoping that every one of us has taken notes of some very key messages that we can take back to our communities and to our congregations. So thank you again, Dr. Shelly. My name is Rolando Santiago. I'm part of the steering committee of the Global Anabaptist Health Network. And we do have a new member of our steering committee. She's our communications director. I want to introduce her. Her name is Pei Poduchnik, and she lives in the state of Vermont. And she is already working very, very much with our communications efforts, and we're very grateful. She's going to announce the next virtual learning and community building session, the 5th one that we've done since we started in September. So May?
Hello, everybody. Thank you for being here. Again, my name's May, and I am very new. Some of you may have already, I've had a chance to meet, and if not, I hope we will have more opportunities in the future. Please mark on your calendar, our next webinar is Saturday, May 15th, and same time, 9:30 New York time. So however that falls on your time zone. Saturday, May 15th, 9:30 in the morning, New York time. And we're going to have two presenters. One who's actually one of our participants right now. We have Dr. Delphine Capassa, and he will be sharing. Both presenters are from Democratic Republic of Congo. We have the privilege of hearing their experiences in. For Dr. Capassa, he is working in Kinshasa. He has a clinic there, and he's sharing about the access to healthcare for these very urban areas, poor urban areas, and during COVID times. The other presenter is Dr. Blaise Koutala, and he is actually researching in France now about the Congolese liver disease, but he's going to be sharing, in addition to his research, some of the context of his work and how that reflects in the arena of research in the international aspect. So please mark that on your calendars. I hope also that if you have ideas of what you want to hear about or topics you want to have discussed, to either send that as a Facebook message if that's how you link with us, or as an email directly to myself or anybody on the steering committee. We'd love to hear from you guys. Our email is Global Anabaptist Health Network, all one long word, @gmail.com. So thank you so much for your time, and looking forward to our next meeting.
Thank you, May. And now I'm passing it on to Jose, who will have final comments and a prayer.
You're muted, Jose.
Jose, you're muted. You're muted, Jose.
Sorry. I would like to thank Dr. Mark Shelly for the great presentation. And I also think it's very important for us to bring some spiritual environment when we talk about this scientific situation. And I noticed that he started with something that I think it's very important for us as Anabaptists, as Christians. Do not be afraid. And I think I'm going to pray about that all of us, even if the situation, it's not the way we liked, and I would like just to say that Portugal, in the middle of January, we had more than 16,000 cases and more than 500 deaths every day. And we are a small country. We went almost collapsing our health system, and do not be afraid. And I was not afraid. We're not afraid. So let's pray and finish this wonderful time. Okay? Let's pray. Dear God, I want to thank you for this wonderful presentation by Dr. Mark Shelly. We always know that you are in the midst of all these situations happening. We know that you are in control. We know that we always give wisdom to the doctors, to the scientists, to find out a good escape. But you say, and we notice, we should not be afraid of anything. And we know that you will keep us fighting and will keep us committed to see the things going on. Thank you for everyone that was present in this presentation. Thank you also for the ones that couldn't make it, but we're sure that they will come. We ask you for the blessing for this weekend. We ask you for your protection and give us your safeness for us during these different times in our lives. In Jesus' name I pray. Amen.
Amen. Thank you. Thank you, everyone.
Thank you, Jose.
Good to